Janssen asking me to release the pipeline for every other pharmaceutical company in the world, which I don't actually have that much involvement with the T-cell trials, but I would make a couple of general statements. Number one, when you look at those survival curves from the international study, we as clinicians, I'm a diagnostic clinician, treating clinician, we must be putting these patients on clinical trials because the current strategies we're using nowadays are not working, number one. Number two, I think that there have been some, again, they're predominantly empiric agents that have been developed, and we saw some of them on slides, romidepsin, et cetera, prylotraxate, et cetera. They're still too empiric to me. They're kind of like fancy chemotherapy. We need to, again, understand the biology of these diseases. And in time, what then will happen is the targets will be declared. And I think that I know in my heart of hearts we will find them. And I hope the stuff's in the sequencing queue right now. I hope it comes off in the next couple of weeks because Philippe and Laurence will be very happy if it does. And I think there's going to be discovery in there that's going to change fundamentally how we approach these diseases. So I think that lots of companies have things in the pipeline. I think as a general statement, and I think we talked about this at lunch or maybe it was in your car, that I think, again, in the T-cell disease like B-cell, we have to move away from standard chemotherapy, standard radiotherapy in some settings and move towards combinations of biologics. And I think of it very much akin to the way we made progress with tuberculosis when we realized that we needed to cobble together multiple agents that were non-cross resistant. Now that's an antibiotic analogy, but I think in lymphoma, we need combinations of biologics. And if there is that lymphoma initiating cell, maybe you will get it as well too. But I think that's still to be tested yet. So I think that's where the field has to go. A very good example is SGN35. So the new agent from Seattle Genetics. That agent is going to work itself into the upfront treatment of Hodgkin very quickly. It's just logical that it should. It has almost no toxicity. And the problem with it is its expense, which is another whole topic, but I think short of that, it's going to cure patients with Hodgkin with very limited toxicity.
I have another pathology question. We had a case, a gastrointestinal case, which had an anaplastic morphology, and it was positive for CD30, all the cells, and very intense. And it was also Epstein-Barr virus positive in all cells. And well, it had a positivity for cytotoxic granules also. So we have it was difficult for us to classify this lymphoma. Do you believe it's a ALK negative anaplastic Epstein-Barr virus positive lymphoma, or?
So that's a tough one. There are some very strong opinions